if I rehash, looking at CTs and why we're needing to size correctly. I mean, fundamentally, everything we've talked about, unlike surgery where you're removing the valve and sewing it in and creating a seal, we have to do that in the native anatomy. And we have to do that with the TAVI in a native anatomy that is really variable. So the valve has to anchor, it has to seal, and it has to open appropriately. And fundamentally, if you don't size it or choose the right valve, if it's under deployed, it doesn't open properly or it pinwheels. And you get leaflet dysfunction, high gradients, or halt. If you don't anchor it properly, you'll get paravalvular leak or embolization. And so, these are all important components, and we use CT, and there's a lot of advantage to CT. And CT is great, but people get too enamored with it. Because the number is there, they think there's a precision to it. Because you trace a number, it doesn't necessarily mean that's the right answer. And there's a lot of it, and it's in the eye of the beholder, right? Just like you say, beauty is in the eye of the beholder, imaging is in the eye of the beholder. It's how each individual person is doing it, but it's also in the person that's acquiring the data. If the data is not acquired well, you're going to get bad measurements. And if the person that's looking at it isn't looking at it correctly, you're going to get bad measurements. So I think these are all important. And so these are fundamental goals. You're trying to assess size. You're trying to assess the sounding structures with the root. You're looking at coronary risk. We've seen some complications, and we can predict that on CT. And you're trying to assess where calcium is. Am I going to get a seal? Am I going to rupture the root? You're looking at vascular access. But when you get these scans, obviously, you need to minimize contrast and radiation, and there's a lot of different analysis tools. But basically, we've talked about 3-Mentio, that's probably the most prominently used one, but there's Circle, there's other programs that you use as well to assess these components. But there's some considerations. In the beginning, people were used to getting coronary CTs, and coronary CTs are mostly diastolic phase. But we sized TAVRs based on systolic phase. And this was an old study, more than 10 years ago. And there is variability of the annulus throughout the cardiac cycle. And in general, diastolic phases are about 10%, diastolic measurements are about 10% smaller than systolic. So especially if you're doing, you're in the borderline sizing, say you're doing a SAPIEN and you're getting 420 in diastole, it may be 450 in systole, and that's a different valve size, potentially. And so understanding that there's a difference and trying to measure in systole, but at the same time, if your systolic phase has a lot of artifact and you can't get a good measurement, then you don't want to use that. And you have to use diastolic and understand that the size may be different. It's also how you create your planes. I've seen this a lot. People create a plane and you're not right at the annular plane. And if you're not really at the annular plane, your measurements are going to be off, and that's important to keep in mind. In addition, there's a lot of other artifacts. It depends on the type of scanner, and that's fairly less common now. I see a lot of places here in India that the 640 slice scanner, but 320. This was more of an issue back when the 64 slice scanners were the norm. And so when you're using 64 slice scanners, you're combining multiple volumes, and then the breath holds are an important component as well. Like this is what you get the step misalignment or stitch artifact, right? This is, you combine multiple volumes, and this volume here is going through the annulus. And so if you do that, you can get, oops, sorry, I was going to go, it moved backwards, but when you combine multiple things and you get a step artifact, you can missize the annulus. This is motion artifact. If someone couldn't do a proper breath hold, that's an important component as well. So you need a high quality scan. And it depends on what it is, but it needs to be, be able to minimize the artifacts of multiple volume sets. You need to ensure minimal artifact on CTs. You need to get the entire cardiac cycle, do measurements in systolic phase, and use dedicated software. And then you can do that, and then you can give a much more informed discussion to the patient. This is a 420 annulus, minimal LVOT calcium, a tricuspid valve with good coronary heights, not much arch calcium, good sentinel anatomy. This is a person that's very low risk for TAVR. And you can confidently say to this patient, If that patient is 70 and getting a 29 millimeter valve, I'd be very comfortable doing it, but and at a low risk. And I think that's important to be able to tell patients that it's a low risk procedure. But then there's other anatomies like this. This is a type 2 bicuspid, and you see here heavy calcium. The sinuses are big. I mean, a very reasonable size. Sinuses are generous, 47. The annulus measures 720. But, this valve is not going to expand symmetrically. There's not LVOT calcium, and the coronary heights are okay. And the aorta is a little bit is big. It's at 5. So, question is this a procedure that can be done? Yes. But understanding the risk, what you're doing, and how you're doing it. And this is a patient in general that we would do asleep, although this case was done awake because the patient was high risk for going to sleep because it's complex anatomy. And so you see it's big root. Ended up post-dilating the valve and got a decent result. But we knew that up front, we were concerned, we were a little bit we did not go aggressive with the balloon because we're worried about root injury, but there was PVL, so we post-dilated. But that strategy of not deploying aggressively up front because we felt pressure was based on our knowledge of the CT scan. Is again, calcified raphes. They're a big problem because they tend to deform the valve and push it in the opposite direction here towards the left coronary cusp. And in a high-risk patient, use of TEE and looking at the calcium and how it pokes into the root as the balloon goes up can be useful as well. And sometimes this fused raphe, and this doesn't have calcium on it. And you see it's, again, non-right fusion, not much calcium. The sinuses were big. They were about 34. We were putting a 26 sapien 3. And what happened in this particular case is because of that fusion, even though it wasn't calcified, the sapien got pushed towards the left coronary cusp as we deployed because the left cusp was not calcified at all. And what ended up happening is we occluded the left main. Even though the sinuses were generous, the left main was here, and basically it was a longish left leaflet, no calcium. The other side was fused, so we ended up pushing it over. So, again, I know that now and I think about it with bicuspids, but those are things that we learn as well. Type 0 bicuspid, again, the seal zone's high. We knew up front. And now this was early on, this was with TEE. Now routinely we go with the other side. You can see how compressed this valve is up here. So we ended up post-dilating the valve, and the gradients were high, they were around 13. And with post-dilatation, it became more circular. You don't need TE to do it, but we saw in TE that it was underexpanded. We would have seen it if we went to a different fluoro view. But knowing the CT, you know that you're going to have to go to that opposing view, look at the valve expansion, and potentially post-dilate it. Effaced sinuses are another big component. There has to be room for the leaflets to go into. And we saw that case with the coronary occlusion where the sinus is effaced, and there's no room for the leaflet to sit, and that's going to occlude the coronary. And so this is a patient with an effaced sinus where as we started to go up here, you see on the TEE that we're sort of poking into the root. And this could have been this is predicted from that CT scan because there was no room in that sinus for those leaflets to sit. And you see here we're poking into the root, the valve is deformed, and we didn't fully deploy the valve, the pressure was high, but there was still a leak. And so we decided to do another gentle post-still, left about 1 cc, and we were to expand the valve and get a result. This is a patient that because we knew the anatomy was higher risk, we modified how we did the procedure. Because if you don't, you can poke into the root, you can create root hematomas, root ruptures, or these hematomas in the sinus as you see here. So you have to be careful with it. And then looking at STJ calcium, another important component. If there's not room, and LVOT calcium, again, another big component. This is anatomy that's just ugly, right? I mean, where do you measure the annulus? Here we're measuring what we think is the annulus, measuring into the calcium, but the valve may not expand into it. It will stay inside of it. Or should you measure inside? And it may be different when you're doing a self-expanding versus a balloon expandable. And anatomy like this is one that you generally should steer away from. If the patient's inoperable, maybe you try something, but understanding the risks up front are important components. And things that we have to think about. And, it's not just about the valve, it's the STJ. This is a patient that needed a 26 valve, but the STJ is circumferentially calcified and measures 23. If the sinus is short in this patient and the balloon hits the STJ, it's going to push the valve in because it's rigid and calcified. If you're doing a self-expanding, it's not going to allow it to expand. Your risk for root injury if you post-dilate is increased as well. So I think these are sort of important components to think about when you look at the CT. And sometimes you really should just stay away from the patient. If anatomy looks like this, no device is going to get a good result. And sometimes we're forced to do them, but it's important that you understand what it is and have that conversation with the patient about risk benefits. I'll stop there since it's over time as it is. Thank you.